Thank you for joining us for the fifth session in our series, From Crisis to Collaboration, Supporting Survivors with Stigmatized Mental Health Experiences. My name is Gabriela Zapata Alma. I use they, them, and ella pronouns, and I'm the Associate Director of the National Center on Domestic Violence, Trauma, and Mental Health. It's my pleasure to provide and offer the information that we have today for our session in honor of Mental Health Awareness Month, mental health treatment in the context of intimate partner violence. Unfortunately, my co-presenter, our center's director, Carol Warshaw, wasn't able to join us today after a family emergency this week. Know that even though she could not be here, her wisdom is present throughout today's session, and we're holding her and her family in our hearts. Now for some troubleshooting tips about this platform. If you get disconnected from today's session at any point, please re-enter the session using the original webinar link that was emailed to you. If the sound is unclear, it's likely because of an unstable internet connection. If this happens to you, feel free to call in for a better audio connection. If you're experiencing technical difficulties, you can directly chat Carla Alegria, Project Manager with our Center, for assistance. If you're unable to contact Carla, please reach out to WebEx Tech Support. Carla will post that phone number in the chat box. We welcome you to use the chat feature to share your thoughts, questions, and resources throughout the session. Your screen may look a little different depending on what kind of device you're using. Usually the chat box can be found at the bottom right of the screen. You may have to click a chat icon that looks like a speech bubble to open it. Let's test the chat feature now. Please introduce yourself in the chat and let us know where you're joining us from today. Our center, including myself, we're located in the Chicago area. We're headquartered in Chicago, although we have staff from all over. Chicago's the unceded homelands of the Council of the Three Fires, the Odawa, the Ojibwe, and the Potawatomi. We invite each person to learn about the land you inhabit. One resource to get started is the website native-land.ca. So here are the topics we're going to cover today. First, we're going to go over just an overview of mental health and domestic violence and what's the context. From there, we're going to talk about what are some initial steps to take as you prepare your practice to really offer mental health services for people who have experienced intimate partner violence, domestic violence. From there, we're going to talk about what are some of those specific clinical approaches that are either evidence-based, evidence-supported, promising practices, as well as what are some ways to just enhance whatever kinds of practices you're using to be more responsive for survivors. And then we'll be sure to round out the session with resources. I want to point to a resource here on the right before we get started, which is a chapter that Carol and I co-authored that can be found in the Handbook of Interpersonal Violence and Abuse Across the Lifespan. We do, with their permission, have a copy of the chapter available on our website, and that's available, like all of our resources are available for free. And so that's a link that will be available in the chat as well as many others. And also after today's session, you'll receive a copy of the slides as well as any resources that I mentioned throughout the session. Now I'm noticing that I don't have access to see the chat, so I'm going to rely on our team members that if any kind of pressing questions come in while while we have slides up, if you can just jump in and read them out loud to me. And then otherwise, we absolutely have time at the end of our session today to be able to go through any questions that folks may have. So first, looking at overview and context, we're going to talk about the mental health impacts of intimate partner violence, IPV in the broader social context, and then specifically when mental health and domestic violence um, become this new dynamic of abuse. Well, it's actually not a new dynamic of abuse, but kind of synergize together in this dynamic of abuse known as mental health coercion. So first and foremost, we know that being abused by one's intimate partner can have a harmful effect on our mental health as well as our substance use. So here's some of the data that we have been able to really analyze and review through our scan and analysis of the available research literature, as well as talking with survivors and advocates. So we know that being victimized by an intimate partner is associated with a 3 times higher risk of experiencing major depressive disorder, post-traumatic stress disorder, as well as engaging in self-injury. We also know it's associated with a 4 times higher risk for suicide attempts, as well as a 6 times higher risk for developing a diagnosable substance use disorder. Unsurprisingly, studies have found high rates of intimate partner violence among women accessing mental health treatment. And I want to pause here for a moment and say that here at the center, we recognize that domestic violence impacts people of all genders. And we also know that women and LGBTQ people are disproportionately impacted by intimate partner violence. And so in the research, many times what's available in the research is surveys and experiences of women, largely because women are disproportionately impacted, but also because there is a history of erasure of LGBTQ people in research. And so I want to just note that here before going on with offering some of these data points. So looking at the research that is available, it's been found that there are much higher rates of experiences of intimate partner violence among women in different kinds of mental health settings when compared with the general population. So around a third of women in outpatient mental health settings, around a third of women in inpatient mental health settings, and then anywhere from 30 to 60% of women in psychiatric, emergency, and acute care settings. And that the trauma associated with intimate partner violence often does not exist in a vacuum for survivors. That very often survivors of domestic and sexual violence have experienced other kinds of trauma, including oppression. And that this may be trauma that begins in even childhood, including adverse childhood experiences that have been linked to an array of different kinds of health and social problems, including experiencing abuse from an intimate partner as well as abusing one's intimate partner. And looking at adverse childhood experiences, the original study looked at experiences within the home before age 18. Things such as physical abuse, emotional abuse, physical neglect, etc. Since then, there's also been a body of research looking at community adverse childhood experiences, things like bullying and out-of-home foster placements. And what's been found is that these community level adverse experiences are also associated with a range of adverse health effects, and that these are, when they're in the context of poverty, those risks are even more increased. So really clarifying what we already know, that poverty is violence. And so in order to really understand the relationship between domestic violence and mental health, we need to start understanding the mental health within the context of the domestic violence as well as other adversities. And so here, looking at domestic violence, mental health, substance use, and trauma in that broader social context, we know that violence on the interpersonal level exists and is intertwined with violence on the community and the societal level. That violence flows towards those that have less power, and that the policies that exist and are shaped by history absolutely create greater risks for people as well as greater barriers in being able to access the resources that can both prevent the harm as well as address the trauma that may result from different harms. And so in order to stop violence on the interpersonal level, we must address violence on the societal level. These two exist and they go hand in hand. So less well recognized are the ways that people who abuse their partners engage in coercive tactics that specifically target a survivor's mental health. This is a form of abuse that's known as mental health coercion. And here's some of the research that we've done. Our research has found that mental health coercion is incredibly common. So this was a study that was done in partnership with the National Domestic Violence Hotline. And so callers to the hotline seeking support, seeking resources, seeking to connect with an advocate were asked whether they'd like to participate in a survey as long as they weren't in active crisis at the time of the call. And so for those that consented to be a part of this research, this is what we learned from them, that 89% of callers had experienced at least one form of mental health coercion. Now, keep in mind that callers were not screened for whether or not they had a mental health diagnosis or had sought out services in the past for mental health. These were just 89% of general callers who were not in crisis at the time of their call and who consented to be a part of the study. 4 and 5 said that a partner had accused them of being quote unquote crazy. 3 and 4 said that the partner deliberately did things in order to make them feel like they were losing their mind. Half said that a partner had threatened to report that they were quote unquote crazy to keep them from getting things that they wanted or needed. And this was most commonly in order of protection or custody of children. And 1 and 2, or let me back up, of those who had tried to get any kind of help around their mental health, 1 and 2 of those said that their partner had actively prevented or tried to discourage them from getting help or taking their prescribed medications. Mental health coercion tactics are designed to use mental health as well as the stigma of mental health to exert power and control over a survivor, to undermine their mental and emotional stability and well-being, to exploit a person's mental health for personal or financial gain, to jeopardize parent-child attachment, which we know is crucial for survivors and their children, to use mental health in order to justify the abuse, to discredit survivors with potential sources of safety and support, and to sabotage access to mental health supports. And so it can be incredibly difficult to access any kind of mental health care in most of our communities. And then we layer on top of that the active sabotage from an abusive partner or ex-partner to try to discourage or prevent a survivor from being able to access that mental health care. And then we can layer on top of that potentially the lack of training across mental health disciplines in the mental health field to truly understand power and control and to offer services that are safe, accessible, effective, and validating, and really truly healing for survivors and their families. Something else that we learned from this survey, from hearing what survivors had shared with us, was that there were these themes around how mental health coercion actively sought to sabotage access to mental health services. And this showed up in two primary ways: the manipulation of treatment and the control of medication. So, under manipulation of treatment, we found that people were sharing with us time and time again that an abusive partner or ex-partner was attempting to influence their mental health diagnosis or their treatment. So, really trying to manipulate the provider and that care that the provider is offering, threatening or attempting to have the partner committed, right? When they, in fact, don't need any kind of institutional mental health care. Withholding resources needed to access care, and this very often was insurance, financial resources, transportation, childcare, really anything that anyone needs in order to be able to access health care. Pathological jealousy. So the allegations around you're having an affair with your counselor or you're having an affair with someone else at that mental health office or that therapy office, etc. Now, on the medication side, survivors shared with us many times that a partner or ex-partner prevented them from being able to take their medication as prescribed, including forcing to medicate, forcing them to take medication or over medicating, taking too much medication, stealing of their medication, which can be incredibly harmful, especially when medications are considered a controlled substance and we're not able to just get another. We're not able to have a replacement of those medications that were stolen, and then emotionally abusing a survivor and insulting them for taking medication. Again, really leveraging both stigma related to mental health as well as substance use in order to denigrate a survivor and keep them from being able to access sources of support. So from that same study that we conducted with the National Domestic Violence Hotline, here's something that a survivor shared with us. He'd tell me I shouldn't get any help or take medications because he didn't want anyone to know about my depression. He'd say things really softly under his breath. And when I'd ask what he had said, he'd tell me I'm crazy and that he didn't say anything. Another survivor shared with us, he told me that if I tried to leave, he was going to take the kids and I would be in the psych ward. And so this raises the question about how does one heal when one is actively under siege, when one is actively experiencing these forms of victimization. And layering on top of that, many times, the lack of safety that many survivors experience in the broader society because of different forms of oppression, bias, and discrimination. So now, looking at how do we create a safe and accessible practice. Now we're going to talk about what do you do first? Where do you start? Right? What's the foundation that we're building here? From there, we're going to talk about confidentiality, documentation, moving beyond screening, how to show up in ways that are validating, and ultimately supporting survivor safety. So first, those initial steps to prepare your practice. And when we say practice, we mean that in the broadest way possible. So that could be your private practice, that could be just meaning your therapy practice within a larger organization, a community mental health organization. That could also mean preparing your practice as you go forth to practice as a therapist or counselor within a DV setting. for example. So understanding that we're using that term practice in the broadest sense possible. So first and foremost, making sure that you and your team, everyone on staff, has universal training on intimate partner violence and mental health coercion, as well as substance use and substance use coercion. Because while in this session, in honor of Mental Health Awareness Month, and also because we only have an hour together today, we're focused on mental health, but very often there are experiences of substance use coercion as well. That all of this builds on an organization or practice that is accessible, culturally responsive, and trauma informed. And so what I'm gonna talk about following from here really solidly rests on this accessible, culturally responsive, and trauma informed foundation. We can't do any of the things I'm gonna be talking about without having those core pieces in place. That we center survivors' self-defined goals and concerns. Anywhere where we are taking a top-down approach is going to be harmful for survivors. Because you have to remember that the experience of trauma is one where we are overwhelmed and overpowered. And the experience of domestic violence is one where someone or more than one person is exerting power and control over us. And so our services cannot be coercive. Our services cannot replicate those same power and control dynamics, or else they will very quickly become not only re traumatizing, but also re victimizing. We need to develop relationships with our local partners and anti-domestic violence advocacy programs. And so, having, for example, mental health staff that are well trained in power and control, understand domestic violence, beautiful. Having integrated programs where the same team can provide both mental health and domestic violence advocacy, beautiful. But at the end of the day, we're not expecting or asking every single mental health program or practitioner to become as knowledgeable as an advocate, not by a long shot. What is really important is being able to develop those working partnerships with those advocacy programs. Advocacy programs are the experts when it comes to supporting survivors in navigating so many different safety needs, so many different kinds of systems and resources. And so we want to be good partners and really work across those silos. And attend to safety and confidentiality. We know that confidentiality is essential in mental health services, in substance use services. When it comes to domestic violence, confidentiality cannot be an afterthought. It cannot be a box that we check somewhere. It must be front and center because a person's very safety is based on that confidentiality. And in order to do any of this, we need to have a culture of staff support and community care within our teams and our organizations. So attending to staff safety, privacy, and confidentiality concerns. So first, ensuring privacy. So things like using professional translators, having advanced directives in place potentially, being aware that when we are collecting collateral information, being aware of what those relationships are and maintaining confidentiality when we do, that everything is done with informed consent, and that when we're talking with people, we're inviting them to speak with us privately. Um, and at the same time, if somebody appears to our services with a partner, and we invite them to speak privately and they decline, it's important not to insist. Because if we insist, then they may face more danger when they leave our space with that person. That said, we do want to find opportunities to be able to speak with them alone, to meet with them alone, in order to be able to have a better sense of who they count as safe and supportive people in their lives, as well as just to offer that private service. If we aren't able to meet with them alone in a given moment, then in those moments, we want to make sure to keep our conversation much more surface level, much more strengths based, goal oriented potentially. And then really, especially in those moments, allow them to set the topics, the tone, the pace. And then recognize ways that an unsafe partner may try to control or sabotage the service. So never ask about abuse or mental health coercion in the presence of someone who hasn't already been identified as a safe person when you met alone with them. Never ask about abuse during a couples therapy appointment when both partners or multiple partners are in the room. Also, these are questions that we want to save for outside of sessions with children or family sessions. Um, and we don't want to be asking, family members or collateral contacts to corroborate any kind of information around domestic violence. It's really important to maintain that privacy in those moments. And the piece around professional translators, we have a really fantastic tip sheet on this for folks who want to learn more. And that tip sheet has a lot of resources to our sister organizations that are truly, truly the experts on this. Um, but here, it's incredibly important because there are certain confidentiality methods and regulations that professional translators are both trained in and beholden to. And we want to make sure also that we aren't using, family members or social supports as translators because it may come out later that there may be some power and control within that relationship. Now, we also need to establish telehealth safety if we're offering any kind of telehealth service, whether that's by video or phone. And so here, ensuring that we're using secure technology, that we're establishing whether the person is alone towards the beginning of the time that we're meeting. We also want to, in advance, plan around any potential safety concerns or if the call drops. It can be helpful to establish a code word that the person can use towards the beginning of the session in order to let us know if it's not a private space, if it's not a private session, or also to have a code word or a code phrase that lets us know if they want us to take some kind of action. Now, we should never take action that the person hasn't specifically asked for or okayed with us, unless there's something that is an immediate threat to somebody's safety. So we want to be sure that we're always using a survivor-led, or we're following the survivor's lead in whatever it is that we're doing. And telehealth can be really helpful for being able to offer more flexibility in times and locations and being creative around times and locations. We also want to discuss options for keeping information confidential when it comes to protecting sensitive information. So we want to talk about our electronic health records, our notes, our billing, our explanation of benefits, how we provide referrals. For example, if it has happened that a somebody was offering services to a survivor's child and billing that child's insurance. And then an unsafe partner who didn't know the location of the survivor and the child put the child on their own insurance and then started getting And then when they put the child on their own insurance, the practice that was seeing the child, rather than confirming insurance with the survivor, just put in the child's information and started billing the insurance that came up. And from there, explanation of benefits got sent to then the unsafe partner, or ex-partner in this case. And that way, that unsafe ex-partner was able to locate the general area of where the survivor and the child had moved to. And so we need to be really thoughtful, really careful, and talk through these pieces with survivors so that we can safety plan together around these pieces. And in this way, it would also be best practice to be able to secure some kind of funding to be able to cover the cost of care and create access for survivors and their families when it's not safe for them to use their own insurance, or they don't have insurance or the financial resources to, of course, be able to pay out of pocket. And then always discussing the limits of confidentiality and not just doing it once at the beginning, but also throughout, reminding people what those limits of confidentiality are so that they can have truly informed decision making as they decide what is safe to share with you and what is not safe to share with you. Now, documentation best practices. Any information that becomes available to someone who's unsafe can increase a person's danger. Records can be subpoenaed and used against a survivor, and this is especially common when it comes to matters around child custody. We have done some analysis around child custody determinations when an abusive partner even just makes an allegation around a survivor's mental health, whether or not that allegation is true. And tragically, what our research has found is that even just the allegation of mental health increases the likelihood that child custody is not awarded to that protective parent, which we know has devastating effects for both the survivor and their children. And we know this is incredibly common. Actually, a brief report um, on new study findings that we just published yesterday. We just published yesterday, found that almost 80% of people who participated in this research, in this study, that were pregnant at the time of abuse had false claims made against them about mental health or substance use from that abusive partner. So we need to be incredibly careful in how and what we document. And thoughtful documentation of the domestic violence and its effects can benefit survivors. It can benefit them when they've been discredited in court proceedings. It can benefit them in being able to prove that the abuse occurred, to improve their credibility, because we know that a big thing that an abusive partner often attacks is a survivor's credibility, especially leveraging mental health and substance use stigma around that. And they can also use records to provide evidence of their being a protective parent. If you do document mental health or substance use, then you also want to be sure to include the connection between symptoms and abuse, if and how the abuse creates any kinds of barriers to participation in services, and a survivor's effort to protect and care for children. And here you see one of our documents, one of our products on confidentiality. We have one on confidentiality broadly, that is confidentiality across DV, mental health, and substance use. And then this one that you see on the screen is specifically around best practices and documentation. Now, if it's safe for someone to talk about mental health coercion, here's some ways that we can help open up that conversation, because we want to move beyond screening. Screening very often is a yes or no answer. It's we ask the question, we check a box. If they say yes, we do something. If they say no, we do nothing, right? And that just isn't a good fit for the realities of domestic violence. In domestic violence, what's important is to focus on building safety for survivors to be able to actually be able to talk with us about what is happening. And as people experience that felt sense of safety, believe me, people can't wait to have someone safe that they can just talk with, right? Without fear of retribution, without fear of punishment, without fear of reporting, right? Just someone safe to talk with and sort through everything they're experiencing. And so, if it is safe for someone to talk with us about mental health coercion, here's a way that we can help get the conversation started. We might say something like, how does your partner support your mental health? We might say, people have shared that sometimes their partners say hurtful things or try to make them think that they're losing their mind. A partner might make it hard to connect with people you trust. Or, on the other hand, might only be supportive during hard times. If you can relate to any of this, we're here to help. Right? And then just allowing for space and seeing what flows from there. Now, on top of being able to open up some conversation, or often what I say, set the table for conversation, we also want to be able to recognize mental health coercion. So here are some things to listen for or to notice. Undermining. Does the partner tell them that they're lazy, that they're stupid, that they're crazy, or that they're a bad parent because of mental health experiences, or that no one will believe them because of mental health? Blaming. Does the partner blame them for the abuse, saying that, the abuse happens because of them and their mental health, or because they're quote unquote crazy? Gaslighting. Does the partner intentionally do things to make them feel like they're losing their mind or that they can't trust what they know to be true? Jeopardizing. Is the partner doing anything that makes the mental health symptoms worse? Very, very common one is keeping someone up all night fighting, interrupting their ability to have any kind of healthy routine around things like sleep or eating, right? Discouraging them from getting any kind of mental health support, things like that. Discrediting them. So, using mental health stigma to undermine them or humiliate them with other people. Threatening. Have they ever threatened to have the person committed to a psychiatric institution? Have they ever threatened that they would lose custody of children because of mental health experiences? And then controlling. Has a partner ever tried to control their mental health experiences, their mental health treatment or prescriptions? Do they restrict their ability to speak for themselves with providers? Do they have control over the person's finances or potentially guardianship? Is the partner legally able to make decisions for them as part of a psychiatric advance directive? Things like that. And then, of course, just really normalizing, discussing mental health coercion and intimate partner violence as part of a mental health history. So, being able to ask about the relationship between mental health symptoms and the current abuse or the previous trauma and coercion. And how does the partner respond when the person's experiencing symptoms or when they're doing well? Or how do they act when they're using versus they're not using? And how might the partner react to the mental health service plan, or if they were to take medications or any other kinds of concerns that might come up? And then with ongoing risks, we want to be able to notice some red flags. And we want to recognize these as red flags of potentially domestic violence and never take any kind of blaming or punitive approach to these things. So missing or coming late to appointments. This is really common because if a survivor is always where they're supposed to be, that becomes a really easy target for stalking and for victimization. Not to mention all the ways that an unsafe partner or ex-partner may actively sabotage a person's ability to engage in mental health care. Losing prescriptions or unable to fill scripts or misplacing medications or running out early, exacerbation of symptoms or experiencing mental health crisis. Many times when we see symptoms increasing or we see there's been a mental health crisis, we focus just on the crisis and we don't focus on what happened and or like what happened in this person's life, in this person's environment that set the stage for this mental health crisis. And when we look back, many times there is something that is trauma related, and that could very well be intimate partner violence. Substance use problems, including overdose, medical complications, injuries, or oversedation, and the partner or other party is overbearing and makes it difficult to see the person alone, to see them privately. Now, how we respond here makes a really big difference. So it's important for us, first and foremost, to respond with validation, to let people know it is never their fault when someone harms them. They always deserve to be treated with dignity and respect. And to really counteract the mental health stigma here. And it's also really important to let people know, I believe you, and you're not alone in this, right? You're not the only one experiencing this, and you also don't have to face this alone. Now here, consent really matters. So before we jump into a conversation around domestic violence, before we jump into a conversation where we're offering resources or strategies, it's really important for us to just ask them, would it be all right if we talked some more about this? Or I have some ideas or of resources that might be helpful. Would it be all right if I shared those, right? One of the reasons many times that people fear talking about things like domestic violence or mental health or substance use is because they fear that they're going to lose control of the conversation and the conversation's just going to become all about that when maybe that's not the most important thing on their list today. Maybe they need to make sure that they have food for their children and for themselves, or they can't go back home right now and they need a safe place to be. And so we want to make sure that at every step of the way, we are offering choice points and that we are not just kind of taking over the conversation. With permission, here we can also just actively listen and offer strengths-based support. So finding out what's been helpful as they've been going through this. Who are some safe supports? What are they doing to keep themselves and their children as safe as possible? What other kinds of supports would be helpful? And would it be helpful to talk about some resources as well as to strategize around safety? Now, in the context of mental health coercion, as a mental health provider, you want to offer some links to an advocate to be able to support with some safety planning, some overall universal general safety planning. And then, as that mental health provider, you can support safety planning specifically around that person's mental health, as well as their ongoing access to mental health supports and services. And I want to be clear that when I say mental health supports and services, and when we say that here at the center, we mean that in the broadest way possible. That includes peer-based mental health support, that includes culturally specific sources of mental health support and healing, in addition to more formal mental health treatment or care. So these are just some areas that you might want to strategize around and consider. Things like legal documents that give an abusive partner or other abusive party control over a person's benefits or care. Things like safely staying connected to mental health services if they start to experience or have been experiencing some of that treatment sabotage. And then, of course, it referrals to anti-violence advocacy organizations. And it's important to know what advocacy organizations do and offer because survivors very often, in my experience, if they haven't worked with an advocate before, they think that they should only work with an advocate if they're looking to leave a relationship, which of course is not the case. And many times, there can also be this sense of just being, having some fear around engaging, and not knowing what to expect. And so if you're a mental health provider and you're already, someone already feels comfortable with you, you can really be that important bridge to that advocacy service and dispel some myths and misconceptions so people know how incredibly helpful advocates can be. And above all else, never advise or try to persuade a survivor to leave a relationship. This is a time that a survivor is at one of the times that they're at highest risk for escalating violence, including being killed by an abusive partner. And so we never, never, never pressure or try to convince or even imply that a survivor should leave an abusive relationship. We should do the exact opposite. What we should do instead is express that unconditional support and respect while offering safety planning support and connection with local advocates. And so we emphasize you're the expert on your experience. You know what you need, whether you're in this relationship, another relationship, no relationship. I am here to support you. You're the one who knows what is best for you, right? And so, with 10 minutes left, I'm going to say a little bit here about clinical approaches, and we have more resources on our website. But I'm going to start prompting folks. If you have a burning question, go ahead and put it in the chat now. We are watching the chat, and so once we get to questions, we can go right into answering the questions that are there. So with clinical approaches, it's incredibly important to use integrated approaches where concerns related to intimate partner violence and trauma are integrated for anything else that somebody else is also experiencing, whether that is substance use or, but that we're doing this in a way that that really supports people and doesn't kind of segment off their experiences. Here, using complex trauma models that really center safety and stability at the core and then build out from there. And so, in this way, mental health care in the context of intimate partner violence should address ongoing risks while supporting stabilization around any kinds of symptoms the person is identifying, while promoting healing and recovery and building that connection and that resilience. We want to take a holistic approach. So we don't want to just focus in on this very individualistic view of just looking at like symptoms or what have you. It's important for us to use a person and environment approach and look at everything else that may be going on around them and support them with those holistic needs that include things like addressing social determinants of health, system navigation, housing and economic concerns, things related to substance use, medical health, including pregnancy, and stigma and any system-related risks, including custody threat, child welfare and legal system involvement, any kind of family or community-related needs or risks, and helping also to address and heal from experiences of discrimination and disparity. We also want to attend to the common concerns that come up with intimate partner violence. So recognizing that abusive partners, they may come across as more stable or healthy than the person that they're abusing. And that makes a lot of sense because they are abusing the other person. The other person is the recipient of that abuse. And so they're experiencing that abuse, that harm, that trauma, right? Um, Something that we do not do is do not focus on helping a person who's being victimized understand why they chose to be in that relationship or why they chose to be abused, right? With time and with safety and with healing, a person may actively ask, you know, I've noticed these patterns in my relationships. Why? Why does that keep happening? Right? And we can talk about, well, what are some of the early warning signs of a partner who is seeking to use power and control? Right? And we can offer some of that information so that people can know what to look for and how to stay safe, while at the same time countering victim blaming narratives. But we have to actively work against in the mental health field any kind of narrative that would lead towards this, well, what about you? Why are you in these relationships, right? That is just a way that blaming shows up in disguise in the mental health field. And it's a very thin disguise at that. We want to discuss suicidality in the context of trauma, and understand why some parts of us may be reaching towards suicidality as that escape, as that relief, to honor those parts of us that are seeking that, to reclaim our power and are seeking that safety and that relief in that way, while also supporting people to find other ways, and establish safety. And to support survivors to distinguish trauma reminders from necessary vigilance. That, when we are experiencing ongoing harm, victimization, stalking, being on edge is important. Having a big startle response is important. Constantly looking over our shoulder and scanning for who's around is a safety method. We don't want to reduce that necessary vigilance. And at the same time, many of these also overlap with trauma symptoms that can be incredibly distressing for people. And so helping people weed through that and um, be able to tolerate the distress and experience the distress while also not being subsumed by it. I'm going to speed ahead because I'm realizing we don't have a whole lot of time left. And so here we want to make sure that we're ensuring choice and control, that we're helping them navigate different kinds of healthcare settings that may be potentially re-traumatizing, that we're considering the impact of trauma, including partner-inflicted brain injury, which I'm going to put in a plug for our 6th and final session in this series in June is all about partner-inflicted brain injury. To strategize with survivors around ways to address mental health and substance use coercion while honoring the complex decisions that they have to weigh. Now, we have a few slides here on what kinds of evidence-based and evidence-supported interventions have been found to be effective in addressing trauma with survivors of intimate partner violence. And so, of course, trauma-informed peer support can be incredibly important. Um, we have here uh, just some information. We did this research, so you didn't have to. Specifically for people experiencing more stigmatized mental health conditions like bipolar and experiencing potentially, alternative perceptions and things like that. What has been found helpful in addressing the effects of trauma, as well as what has been found helpful for integrated approaches to addressing co-occurring concerns related to mental health and substance use. And with much more information, we have our online repository of IPV specific trauma interventions, where you can learn a lot more around what research is out there that actually included survivors, because too often survivors are excluded from the research on trauma interventions. But most importantly, no matter what kind of mental health approach you may use, and the vast majority of us use an eclectic approach. So, no matter what kind of mental health intervention or approach you may be using, our systematic review found that these 5 elements can enhance whatever it is that you're doing to make it more accessible and effective and responsive for people experiencing intimate partner violence. So, first, sharing information on the real causes and consequences of intimate partner violence, including the traumatic effects. Second, awareness of mental health and substance use coercion, including the sabotaging of recovery efforts. Third, attention to ongoing safety and supporting with safety planning. Fourth, cognitive and emotional coping skill development to address trauma-related symptoms and support their self-defined goals. And finally, fifth, a focus on survivor strengths as well as the strengths of their culture and their community. So with that, I want to say thank you so much for making the time for being here today. I'm going to zip through some additional resources. This is our newest resource published just this month. Woohoo! We're so excited. But we have a bunch of different resources available for free on our website, and available in different languages, and more languages coming soon. And I want to go ahead and open it up for questions.
Hi, Gabriella. It's Carla. So, one of the first questions I was asked is what other strategies would you recommend for providers offering services telephonically or virtually?
Yes. Really, the top ones are going to come around establishing safety towards the beginning of the session, and letting the person bring up the, abuse or deeper topics, until we're really sure that they're in a confidential space. There may be times where we need to prioritize someone for in person because if that's accessible for them, because there's really no time that somebody isn't listening in, or choosing a therapy that focuses on the future and focuses on coping versus focusing on problems in the past. Because then, if we're using that strengths-based approach, there's a lot that we can do to help someone without them having to kind of share a lot of information that an abusive partner may harm them for sharing.
Another question we have is it comes in the form of a little more information, so I'll go to their second part. So we have had mental health providers who put limits on the amount of appointments that can be missed, sometimes as few as two. How can we limit penalization of survivors given the many complex reasons they may be missing appointments, as you mentioned?
Yes, unfortunately, it's far too common. The current payment structures for mental health services make it so that mental health providers have a really hard time continuing to operate when there are many missed appointments. And so for that reason, many providers have just automatic um, involuntary discharges if people miss. And so, as we want to advocate absolutely for there to be flexibility, for there to be ability to reschedule, we want to advocate for there to be understanding of a person's situation. Um, and we also want to do our best to really support survivors in addressing all those different mental health coercion tactics, like the withholding of transportation, withholding of childcare, um, Just this week, the National Mental Health Care, Maternal Mental Health Care Strategy was launched. Our center's director, Carol Warshaw, was on the task force that was a part of creating that national strategy. And one of the first things they name is that in order to address maternal mental health, all the mental health care providers have to have quality, intact childcare available. How can people access mental health if they're reliant on others for childcare and they can't bring their children with? So a lot of pieces that we can do to advocate as well as to make sure that people have access to those tangible resources. Um, and then, connecting people with maybe drop-in spaces, spaces that can be more flexible and accessible for them, that maybe don't offer the same kind of mental health service, but that ultimately will be more accessible and will be better than nothing if the mental health provider is unable or unwilling to be flexible.
Great. We have a couple more comments. I know that we're at time. I have logged them, so we could do our best to respond now or save them for later.
Yeah, thanks so much for flagging that, Carla. So what I'll say is that our organization offers free technical assistance. And so we are so glad that you tuned in today. And if there are remaining questions, please, please, please feel free to reach out to us. You can reach out to us by emailing info@ncdvtmh.org. You can also use our contact us form on our website. And then we also have a phone number and a TTY line on our website that I'm sure we can also drop in the chat, and as well as send out with the follow-up email that will have the slides and the resources we talked about. And so I want to just thank everyone. Thank you for this wonderful session. Many thanks to our team of at NCDVTMH, as well as our interpreters, Claudia, Cheryl, and Vera. And thank you to everyone that joined us today. We know that you're incredibly busy. You have so much happening. So thank you for carving out the time to be with us. You'll have a survey. We really want to hear from you on what we did well, as well as how we could improve in the future, as well as what topics you want to hear about from us, right? What could we be talking about that's important? Within the next week or so, we'll send you that follow-up email with a link to the recording, as well as slides and handouts, and they'll also be available on our website. And for folks who'd like a certificate of attendance, you'll have that as well. Thanks again, and wishing everyone a wonderful rest of your day.